morning, everybody. I'm actually absolutely delighted to be here this morning and share with you a topic close to me. And before going through our experience in Saudi Arabia, I would like to express my gratitude to the organizing committee for extending this invitation and giving me this platform to speak about DADA 2 and our experience in Saudi Arabia. So I have no conflict of interest to disclose. So through the presentation, I will take you through the epidemiology and clinical feature diagnosis and current and previous therapies for our cohort, and then the outcomes of the cohort. And I will try to compare each section with the existing data, trying to show you the unique characteristics of our patient. So we have identified 21 patients from 14 families. Among these patients, 19 were found to have homozygous mutation. One patient only with compound heterozygous mutation, and one patient was symptomatic carrier. So they were reported from 7 major tertiary centers, highlighting the wide reach of our cohort. The diagnosis was up till September 2021. And they were reported from across various sections of subspecialties, including immunology, rheumatology, and the hematology department. So the male-female ratio was 1 to 1.5. The 14 families came from various tribes, and you can see here the map of Kingdom of Saudi Arabia, and you can see the distribution from most of the areas in the north, south, and west and central part. No patient from the eastern province, probably because of hospitals were not involved. However, more of the patient from the north, but it's nothing specific, and the distribution all over the country. So we didn't think this is the frequency in Saudi Arabia. We think it's more common if you compare it to the frequency in the literature reaching 1 in every 222,000. So we think it's more common. There are some limitations which can be attributed to our cohort or can be seen elsewhere. So the first limitation is we think the selection bias. So not all the hospitals included in our cohort, particularly the secondary hospitals. The disease is well known to be characterized with lack of awareness among physicians, and also the variable phenotypes, which can lead to difficult or delayed diagnosis. Furthermore, some patients, they have mild disease, which might be undiagnosed for years. Another difficulty in the diagnosis is the unavailability of the enzyme testing in most of the countries, including our country. So Saudi Arabia is well known with higher consanguinity, which may reach up to more than 50% in some areas, which is likely to be associated with higher risk of the disease. And lastly, the screening of the sibling was not available in all of the 14 families. So DADA 2 is usually a childhood disease. So this is the median age of onset in our cohort. It was 1.5 years. And compared to the literature ranging between 4 to 7, the range from 0 to 24, we have 2 patients presented actually on the postnatal exam with inguinal lymph node enlargement. So it can be soon after birth. 35 of the patients presented before 1 year of age, and 25 less than 5 months of age, and all except presented before 10 years old. The median age of the study cohort at the time of the study was 9.5 years, ranging between 4 to 26. So this table is showing you the initial clinical manifestation of our cohort, and it's clearly showing the hematologic manifestation of the cytopenias is the commonest clinical feature at disease onset, followed by recurrent fever, organomegaly, and lymph node enlargement. Hodgkin lymphoma was observed in 3 patients, and you can see the list of other clinical manifestations. Screening of 2 families revealed 3 patients diagnosed with molecular genetic testing. So this table is, might be busy, but it serves to effectively summarize the clinical features of our cohort. It compares the clinical features to the initial description of the disease in 2014, prior to the expanded understanding of the disease. And it also it compares to 2 recent publications. And the last one, a few months ago, 2023, which is a single-arm meta-analysis analyzed and studied 378 patients published in the literature. So if you look at each clinical feature, trying to give you a comprehensive overview of the clinical features. So the recurrent fever, it seemed to be much less common than the initial description, but it's close to the overall description in the literature. The cutaneous fever is much less in our cohort. The ischemic stroke, hepatosplenomegaly, and the hypogammaglobulinemia, all of them is similar to the published data. If you see the hematological manifestations in our cohort, it's much more common. The pancytopenia here is 40% compared to about 5% in the literature. The severe anemia also is much more common, and here it's 25 in the published literature. This should be for 7%. So the severe anemia is much more common in our cohort. Also the neutropenia and thrombocytopenia. So to conclude, Saudi patient, the disease in these patients, you will see there is less frequent but not significant in terms of recurrent fever and cutaneous manifestation. The hematological manifestation is significantly more common. And stroke immunological manifestation and the organomegaly, they have similar frequency compared to published data. So if you go in detail in the hematological manifestation, the anemia, and 10 patients, 70% similar to pure red cell aplasia. With these patients, they have frequent blood transfusion, marked reduced erythrocyte, and the precursor of the bone marrow of 4 patients. 4 patients with iron overload and an iron chelating agent. The neutropenia is in 15% of the patients. It is severe in about 70%, and most of them the GCSF. The thrombocytopenia, 3 times more common than the published literature, and it's mostly mild to moderate. 1/3 suffered from severe anemia, and the thrombobag was used in 1 patient. So for the neurological manifestation, the MRI was performed in 15 out of the 20 patients, and 6 of these patients found to have ischemic stroke, and 1 of them, in addition, found to have CNS bleed. This is a brain image with MRI of 1 of the patients. He presented at the age of 4 years. He presented with neutropenia and recurrent mouth ulcer with hepatosplenomegaly. He remained undiagnosed for 5 years. After the screening of the families, he found to have DADA2 conferred by molecular genetic testing, and he remained for 2 years. We're not aware that you have to screen for the ischemic stroke, looking for any silent stroke. At the age of 11 years, the brain MRI showed As you can see here, old ischemic stroke at the basal ganglia. He was started in the NTTNF, and he remained stable for the last 3 years. So these, the rare complications in our cohort included growth retardation, complicated GI ischemia, and spinal cord infarction resembling transverse myelitis and Hodgkin lymphoma in 3 patients with similar mutations. So these rare complications significantly impact the patient life, and the growth retardation, which is seen in a significant number of our patients, it is not well described in the literature. So for the diagnosis, the median age between the initial presentation of our cohort and the diagnosis was 3.3 years, ranging between 0.2 to 10 years. The ADA actually confirmed the diagnosis in 5 of our patients, while the whole cohort, the molecular genetic testing confirmed the diagnosis. This is showing you the graph of the enzyme testing. The 5 patients showed activity loss, which coincided with the predominance of the hematological manifestations. So 4 patients it was undetectable level, and 1 patient really absent. So we found 7 genetic mutations. The commonest one is the C1447 deletion, 40%, and the C882 in 30%, and the 1379 in 10%. And it's worth mentioning that 2 patients were diagnosed after death. So this is the list of remaining mutation, and one of them, as I mentioned, with compound heterozygous mutation. So although the hematological manifestation predominates in both genotype, as you can see here in the table, if you look at the 2 common mutations in our cohort, there is significant differences in the clinical features. So the transfusion-dependent anemia and malignancy were observed in the C1447 mutation, and none of the patients in the C882 mutation suffered from severe anemia. However, the symptoms between the 2 mutations overlap, suggesting continuum spectrum rather than the district categories. So this is showing you the therapy in our cohort. So the anti-TNF currently in 9 patients, the transfusion in 4 patients, and the cyclosporin and the G-CSF in 3 patients, and IVIG in 2 patients, and 1 patient underwent hematopoietic stem cell transplant. His clinical course was predominated by bone marrow failure and lymphoproliferation. He's the earliest reported in the literature with ALPS-like phenotype, and he was cured with matched sibling donor. So currently, we have 4 patients referred to the hematopoietic stem cell transplant, 3 patients with pure red cell aplasia, and 1 patient with pancytopenia and recurrent infection. So this is summarizing the outcome of our cohort. 4 patients planned for the transplant at the time of publication. 3 patients died, with 2 patients with septic multi-organ failure, and 1 patient with fulminant hepatitis, 9 patients on on anti-TNF, 6 on adalimumab, and 2 on etanercept, and 1 on infliximab. So for Saudi cohort with DADA2, this is the summary. The median age of the disease onset was earlier compared to the published literature. Most patients were initially actually referred and diagnosed by hematologists because of the predominance of the hematological phenotype. And the main treatment included anti-TNF blood transfusion and the G-CSF. 25% of our cohort required hematopoietic stem cell transplant, and the mortality 15% of the patients. So on behalf of my team, we would like to thank patient and their parent for participating in the study. We'd like to thank Michael Hirschfeld for his invaluable assistance in testing our patient, and would like to thank Isabel Mates and Chip Chubber and DADA Foundation for their continuous support toward our research. And I would like also to thank my exceptional team. Thank you.
Well, thank you very much. We do have some time for questions. Are there any questions from the group? Ivona, it looks like you're making your way to the microphone.
Thank you. Good morning. Thank you for this presentation. Actually, my question is not related just to your cohort, but just in general to all of us. So it seems to me that despite the great progress we made in the past 8 years in finding or identifying more than 600 patients, based on the study from Puyi's Lee's lab, it seems like we are still, or the patients or this disease is still largely undiagnosed. And I'm not talking about some small countries. I mean, having 18 patients or 30 patients in Brazil, where population is almost 300 million, or, in many other countries, it tells me that, we need to not just to work on patient registry, but we need to think about how do we go from here to diagnose more patients in all these countries. And so, there are different, I guess, options to do that. One of that would be to talk more about the other two, in other medical communities, such as, dermatologists or hematologists, and to educate physicians in other countries, in other communities about this disease. Another thing that came to another thought I had this morning was, or maybe we should just distribute some kits, like this Zavialov, COVID-like kit, which, could be distributed to many clinics throughout the world. Huh? Newborn screening, yeah, but that's going to take a little bit more time, to establish, right? Yeah, it is. But, I was just thinking, what is the opinion of the community, how we should really, work on diagnosing more patients? Because to me, this seems to be an important issue.
Yeah, it is an important issue, and since you raise it here with our current speaker, why don't we start with his opinion and what's maybe being done in Saudi Arabia, if anything.
I think I mentioned some of the limitations. One of the major issues is to improve the awareness among physicians. Chip mentioned yesterday the bedside testing, which is really helpful. Since you can see, for example, our cases, molecular testing is the only one is to test, since the enzyme testing is not available. So usually the physicians, if the diagnosis is difficult, they will keep the patient. They will just manage the symptoms. If there's any neutropenia, they will give GCSF, for example, requirement of transfusion. They will give transfusion, but the diagnosis will be delayed, which will affect the management. So awareness is a major, and the testing, these two, a few improvements, I will think you will have more cases.
Joris, do you have a comment?
Yeah, and then maybe adding to that, because this is a field of data 2 specialists, and so we are all aware of these things. But for example, like you, we work also on MAS. So if in the MAS community, it becomes known that MAS can be a complication or a presenting symptom for data 2, as for the neurological, as for the oncology department. So I think we should work on those podia as well, actually. We know it, but those other podia should know it as well.
Yeah. Mm-hmm. Yeah, Amanda, you had a comment.
Yeah, well, this is a great question, and it's something I wrestle with all the time in my brain, is that I do feel like in actuality we're failing to identify these patients worldwide and in the US as well. And I think awareness is great and bedside testing is great, but still you have to think of the disease in order to want to do the bedside testing. So, and I often make the statement to people that in actuality, data 2 patients could wind up in just about any subspecialty clinic because the disease can be so broad. And so spreading the awareness to every subspecialty is really, really hard. So things that I think that we're trying to do, yes, newborn screening is very controversial, so that's going to take time. But if we could just continue to try to add it to panels, like I was texting Natalie, maybe we need to get on the HLH panels and make sure that we get ADA2 added on to the HLA panels that you can do genetic testing for. Or some of the other panels, like it's already on, like the aplastic anemia panels, and continuing to add it there. And that's where we're going to start to pick up some more of these patients. And, Oh, great.
coming up here to add on.
Yes.
Keep going, keep going.
And so I think that's going to be one of the ways we can start picking up on these patients. But I really do think that just continuing to talk and talk and talk is going to get us there a lot of the time, especially in some of these countries where the genetic testing isn't quite so readily available. You just got to, I mean, maybe it's going to take hanging up a sign in somebody's nephrology clinic that if you see this, think about this and contact us, you know, something so rudimentary. But again, I wrestle with this all the time, knowing how few cases we've identified.
One of the things I was going to add is I'm trying to lobby to get this covered on the American College of Medical Genetics secondary findings list, meaning that if DATA2 is found on an exome genetic test of any form, that means that labs will be obligated to report it. Getting on that list also just increases awareness in general. It means that geneticists and other providers are thinking about it because it's something that might come up. So fingers crossed, lobby the ACMG if, you know, they're evaluating it now.
Yeah. Mike, did you have a?
I just wanted to make a comment about the Netherlands cohort. Your neurology colleague had presented at a stroke meeting recently, and she says they're starting to test anybody with unexplained stroke. So I think also, you know, no, in the Netherlands. So I think having accumulated 30 patients in like a smallish country, I think a lot of the increased testing is what really identifies a lot of these patients.
Mike?
Yeah, maybe I've missed this, but has there been any report of the frequency of asymptomatic or pre-symptomatic siblings or family members who, in fact, have DATA2 in your various cohorts?
Well, starting with our current speaker, any reports of?
I mean, from our cohort, we checked 2 families actually, and one of them I mentioned with the silent stroke. He was actually symptomatic and diagnosed. And this is one of the things to identify more patients is to screen. I mean, should be part of the management of the patients is to screen all the family.
You know, just since I don't think about this all the time, I'm just wondering if that wouldn't give some indication of kind of how big the iceberg is that you might be missing.
Yeah, I think definitely it will help. I mean, in identifying more patients. If you look at the screening, how is all of the cohorts were presented this morning. How many of the family were screened? I don't think it's all of them.
Yeah, and in these big
Yes.
consanguineous families, you might think that there would be a number of carriers out there, you know, in other branches of the family. Paul, I think you're going to have the last word because we'll have to move on.
So neonatal screening is the answer, but my question is GCSF. I've always been worried about advising GCSF and neutropenia for DATA2 for fear of inducing a vasculitic flare, stroke. Has that been anyone's experience? I noticed you said some patients receive GCSF. Maybe
Yeah.
I'm being too cautious. What do people think?
If you look at just to answer regarding our cohort is the hematological predominance was almost in terms of vasculitis. It was some of them with actually absent manifestation, and the GCSF didn't have any complication related to the GCSF in our cohort. You might have, sometimes in these patients, acute infection with, absent neutrophils. So probably in this situation, I will suggest the GCSF.
All right. Well,
Okay.
thank you very
Okay.
much.
Thank
We're
you.
going to have to call this session to a close.